or from thyroid or extra thyroid origin. Extra thyroid origin such as thyroid lymphoma or even it is rare. 0.5% from all human malignancy, from endocrine malignancy, more than 95% of all higher estrogen receptor in the thyroid gland. So thyroid cancer comprises of 5 to 15% of all thyroid nodules. So this is the prevalence, the percentage of the UTC. So for DTC, you have papillary thyroid carcinoma, follicular thyroid carcinoma. Total cell carcinoma. So for follicular thyroid carcinoma, whereas histologically there will be abundance of total cell. Whenever a patient indicate a poor prognosis. So generally for differentiated thyroid carcinoma, it has one because it is difficult for you to differentiate patients. So mainly is from history. Carcinoma is 90% of your diagnosis. So you need to be thorough in your history. Age is important. Memang it's important to know the epidemiology, which is what papillary, which is more common in follicular. And then in this patient had anterior neck swelling, if rapidly increased in size, malignancy. Probably there is multinodular goiter, or even there is thyroid with enlarged lymph node. Okay, so also you need to ask about the local compressive symptoms. Uh, Trachea, for if compressed to the trachea, is can cause patient will have difficulty in swallowing. If a patient presented with hoarseness of voice, there is it's highly indicate that this possibly involve thyroid malignancy, because the recurrent laryngeal nerve palsy cause hoarseness of voice. The infiltration into the recurrent laryngeal nerve can be unilateral or bilateral. If unilateral cause hoarseness of voice, if bilateral patient can develop tracheomalacia. And then you need to ask the metastatic symptom, the constitutional symptom, fever, weight loss, weight gain, because usually in cancer, in tumor, in thyroid nodules, patient usually is asymptomatic, only presented with swelling only. Patient do not have rarely have hyperthyroid symptoms. So you can still ask the patient of all these hyperthyroid symptoms, because probably if patient had hyperthyroid symptom with neck swelling, probably patient have toxic thyroid nodule. Toxic meaning that there is elevation of circulating thyroid hormone. Okay. So hyperthyroid symptom is very unlikely cancer tissue doesn't secrete thyroid hormone. Some follicular thyroid cancer can be functional. So most thyroid cancer is just people calling incidentaloma, which is only incidental findings during routine ultrasound or even chest punya CT scan, just incidental finding. Okay, patient kena pun tak perasan they have like neck swelling. Okay, alright. So for risk factor, history of neck radiation is important, particularly for lymphoma. And then family history of thyroid cancer. And then genetic is Cowden and Gardner syndrome is rare. Macam our lecturer tak berapa tanya, they particularly uh, suka tanya pasal men. Men is multiple endocrine neoplasia. There is men 1 and men 2. For men 2, there is men 2A and men 2B. For men 1 is PPP, which is parathyroid pituitary and pancreas. Okay. In men 2, there is medullary carcinoma, hypoparathyroid, and pheochromocytoma. In men 2B, pheochromocytoma, medullary carcinoma, as well as patient had some Marfan syndrome. Okay. Okay, so the history is particularly important when you going for PMP as well as your long case. Okay, so this is what to ask. And then for physical examination, this is very important, because thyroid swelling is lump and bump is common in surgery. You can get the case. So today physical examination is about 2, which is to answer PMP as well as to help you in your short case, or in your main OSCE. So generally memang kalau korang yang dah biasa baca buku Dr. Naim's, it's about 2C and 2P's, the universal precaution. So harap korang boleh add as your habit. Jadikan as korang punya 2C is consent and chaperone, 2P is position and privacy. Privacy is about your exposure, about your privacy of the patients. Okay, so generally in thyroid swelling, patient usually thyroid. How you want to confirm this is you do the peripheral thyroid status examination. What to look for is basically you apa? Usually kalau in short case you would need to check this kalau korang ada masa towards the end. Jangan buat mula-mula because in exam short case it very direct. Kalau disuruh buat neck terus. Jangan korang buat peripheral examination dulu. Kalau surgery peripheral examination is last. Kalau korang ada time, make sure the first when they ask you to palpate the neck, go for neck straight. Tapi korang kena buat lah general inspection, general examination, general inspection of the neck. Okay. So kalau start dengan peripheral, your hand, tengok ada sweaty hand, cold clammy hand in hypothyroid, tengok fine tremor. Korang kena letak kertas on the patient hand, and then you palpate for the heart rate, look at any tachycardic or even AF, irregular pulse, and then you go proximally, you test for proximal myopathy, and then look at the face, look at the exophthalmos. It's basically a thyroid eye disease is specific for grave disease. Other diagnosis for thyroid doesn't involve the eye. Okay, so korang if listen to patient voice, if there is hoarseness of voice, is indicate of recurrent laryngeal nerve palsy. And then you go okay, so bila korang dah for the face tu banyak benda lah korang boleh buat, which is tengok lilac, diplopia, ophthalmoplegia. Okay. Alright, so thyroid usually in thyroid swelling really firm to hard. Kalau hard is almost always cancer. Also can kalau firm tu possibility is can be both benign and malignant. And then if the size is more than 4 cm, it indicates a large thyroid, which is needs surgery. Okay, 4 cm large, more than 4 cm, you will opt for in case of papillary thyroid CA, we go for large thyroidectomy. Total thyroidectomy. So if there is fixation, thyroid muscle involvement such as ACM. Fixation is you would test the mobility of the mass. If it is fixed to the skin as well as to the underlying muscle, so it almost always will be malignancy because of its invasive character. So next is palpable lymph nodes. So first, kalau short case of surgery, they ask you to palpate the thyroid, the neck. So korang kena palpate the neck, start with the neck, which is inspection. Inspection tu, so first is make sure patient duduk atas kerusi. Kalau patient atas bed, minta kalau ada kerusi, minta kerusi dengan examiner, minta duduk patient atas bed sebab senang korang nak bergerak. Okay. Dudukkan patient atas kerusi, inspect. Inspect ni daripada 3 side. From front, from side and from behind. So inspect from front tu tengok betul-betul the scar, apa benda semua, the shape, and the side dekat mana. And then lepas tu bila daripada depan tu korang inspect, lepas tu minta patient how you want to differentiate thyroid punya swelling from other swelling is you ask the patient to drink some air sikit je, sebab tapi usually patient in thyroid punya exam very experienced. So patient dah bawa air siap-siap apa benda semua, korang ask the patient minum sikit, jangan telan lagi, telan bila kita suruh. Okay, so bila telan bila kita suruh tu, and then patient minum, akan simpan dulu dalam mulut dia, bila kita cakap telan, korang inspect, and then percuss cara memperkas thyroid, and then you auscultate for buoy only. Okay, then you want to check for the lymph node ada preauricular, occiput, apa benda semua along the cervical, okay, in the supraclavicular lymph node, the level 7, and then okay, so kalau korang ada jumpa palpable lymph node, describe the lymph node also. Korang kalau jumpa banyak banyak multiple nodules, korang kena describe each of the nodules, right, left, kalau right yang atas bawah, or even because probably atas bawah tu probably mungkin boleh jadi lymph node. So it will have different consistency of the lymph node as well as the thyroid swelling. So kalau ada palpable lymph node, korang put in mind this is papillary type of thyroid cancer. Alright. Okay, then bila neck, go to the lymph node, then you check for retrosternal extension. So retrosternal extension, korang kena percuss the chest from three position, from yang secara vertical and oblique, right left. So korang dari bawah ke atas, obliquely and also vertically. Okay. Lepas tu baru kalau ada masa lagi, you ask the examiner, I would like to proceed with peripheral thyroid examination. So lepas tu probably dia akan cakap, okay, no need, this patient euthyroid, no peripheral thyroid symptom sign. Okay, so dah done with history and physical examination. So trigger 2, upon further history, she noticed anterior neck swelling, bukan 3 months, 6 months ago, when putting on her makeup, initially small in size, about 10 cents, it gradually increased in size over the period, currently about the size of ping pong ball. So it shows that it grows. So possibly it is a malignancy rather than a benign kind of swelling. Otherwise, no skin changes, no discharge, no pain, no compression symptoms, stridor or difficulty in swallowing, no voice, no constitutional symptoms, no metastatic symptoms such as lung mets, brain mets, bone mets, no hyperthyroid symptoms such as loss of weight, diarrhea, tremor, heat intolerance, no hyperthyroid symptoms. Her older sister with similar problem, the surgery 5 years ago, no family history of malignancy, no family history of malignancy. Is important you ask about the main syndrome, okay, as well as other solid tumor causing secondary mets to the, okay, not smoking, drinking, alcohol, apa benda semua, married with 3 children. Okay, so this is the script for kalau korang nak present case. Okay, what you need to, apa yang kena ada dalam korang punya script during. So the patient is ni first paragraph is the general examination. Patient is 35 years old. Gentleman, lady, she is alert, conscious and lying comfortably on the bed. She is staying, not caresick, not dyspneic. no stridor or wheezing is heard. Okay, lepas tu korang komen lah pasal dia punya voice, no hoarseness of voice, normal voice. Okay, there is a alarm. Ni baru korang masuk the thyroid punya ni. There is alarm at anterior midline measuring 5 by 5 centimeter, round in shape. Dalam move with swallowing but do not move with protruding the tongue. So this is to differentiate from thyroid punya swelling as well as the thyroglossosis. Okay, thyroglossosis will move by protruding the tongue because of the embryological nature of thyroid punya descent. Okay, upon palpation, the lump is non-tender, the skin is not attached to the underlying structure, surface is irregular, it is consistency is firm. So kalau macam how to differentiate soft, firm and hard is, kalau hard is kalau korang cuba tekan on your dahi, firm you tekan on your nose, and then soft is tekan korang punya bibir, and the edge is ill-defined. So ill-defined firm to hard is indicate of malignancy. And one percussion is dull. Dull maknanya hard lah kan. The buoy is absent, trachea is not deviated. Lagi satu yang lupa palpate trachea, tengok ada trachea deviation or not. There's no retrosternal extension of voice is not affected. So by bila korang dah, contohnya short case, kalau dah dapat yang ni, dia akan tanya what's your provisional diagnosis based on your finding. So korang kena betul-betul tally lah, janganlah kata irregular, lepas tu soft, lepas tu ill-defined. Memang tak make sense lah kan. So make sure tally, tapi jangan pula korang create the sign lah. Kalau korang create the sign, lagi bahaya. Tapi kalau even korang rasa soft, korang boleh cakap soft, then the lecturer will ask, are you sure? Kalau bila lecturer cakap, are you sure? Cakap, I'm not really sure. So probably ada lecturer yang baik, dia akan suruh korang palpate balik apa benda semua. So macam tu, don't create sign. Rather than admit you cannot really appreciate apa benda semua. Okay. And then state your provisional diagnosis. And okay, so after kalau in short case, dia akan tanya what's your provisional, what's your differential. So kalau dia tanya differential, korang cakap 3 yang wajib ada dia nak dengar is follicular cyst, follicular adenoma, follicular cancer. Itu dah 3 differential. Lepas tu korang boleh, kalau korang rasa even if there is only one nodule, still there is possibility of multinodular goiter, because sometimes there is only one microscopic goiter, but they have some microscopic yang kita cannot palpate. Only by ultrasound only we can know that it is multinodular. So by examination alone, cannot confirm yet whether it is solitary or multinodular. So in your differential, letak je multinodular, so solitary thyroid nodule. Okay, and if patient had symptoms, korang kena cakap yes, toxic adenoma or toxic multinodular goiter. So depend on that. So provisional diagnosis, a complete diagnosis is comprised of 4 these features. Okay, kalau korang in your PMP, dia akan tanya state your provisional diagnosis for 4 markahan. So maknanya korang kena ada 4 benda ni lah. Either from the description it show solitary or multinodular or diffuse, or even the thyroid status, whether it is euthyroid, euthyroid, no symptoms, hyperthyroid or hypothyroid. Starting comprehensive symptoms, tadilah by history as well as physical examination, and korang dengar ada stridor ke, ada macam difficulty in breathing ke, dan so korang kena state all this. Kalau even kalau tak ada pun, just cakap multinodular goiter in euthyroid state with no obstructive or compressive symptoms and no malignancy features. So just state. Kalau no pun cakap no je. But you need to have a complete diagnosis. Okay, this is important. Okay, kalau korang nak buat diagnosis of thyroid, kena ada semua benda, 4 komponen ni perlu ada in your provisional diagnosis, full diagnosis. Okay, next is investigation. Kita dah buat introduction, epidemiology, history, physical examination. Next is investigation. So for investigation in surgery, cuba biasakan diri, or even bukan surgery lah, in your, tak kira apa-apa, try to always classify to bedside, blood imaging and biopsy. Biopsy is particularly in case of cancer kan. Alright, so kalau yang ada punya, other than tumor or cancer, cukup sampai imaging saja. Okay, so for blood, korang janganlah bila doktor tanya what investigation you want to do, korang cakap FBC, RP, LFT, basic, save time terus, because investigation is only 5% of your diagnosis. Is to confirm your diagnosis as well as to exclude your differential diagnosis. Confirm your professional and exclude your differential. So the third objective only to do the baseline. So baru korang masukkan FBC. Bukan tak boleh buat, memang normally routinely kita akan buat FBC, RP, LFT, kan, fasting sugar profile, benda semua. Okay, so for bedside, korang ada contohnya korang buat ECG to look for arterial fibrillation if patient is hyperthyroid, and cakap nak buat ECG, nak look for AF. So bila dia tanya AF, apa benda yang AF punya finding in ECG kan, orang cakap lah absent P wave, irregular rhythm, benda semua. Okay. Alright, so investigation blood, because blood, first thing first is you need to do thyroid function test. Okay, thyroid function test is important to know the thyroid status. Okay, patient probably have no symptom but elevation of T4, because no clinical symptoms, either normal or elevated biochemical thyroid function status, patient is subclinical. Kalau elevated T4 is subclinical hyperthyroidism. If low T4 or normal T4, patient can have subclinical hyperthyroid. Okay. So other than that is you can send for anti-thyroid antibodies. It's particular for thyroid peroxidase in case of Graves' disease, anti-thyroglobulin in Hashimoto thyroiditis. Then you can ask for serum calcitonin as well as carcinoembryonic antigen in case of medullary carcinoma, and want to send for serum thyroglobulin as a baseline for monitoring post-op recurrence. Okay, then other is baseline investigation pre-operatively or just to know the functional status of the patient. For example, patient ada DM ke apa benda, nak tahu dia punya blood glucose punya control, you send for HbA1c. Then ada, kalau patient ada CKD ke apa, ada heart failure, look at the renal function, liver function, all that. Next is investigation. So investigation is imaging. Imaging is okay. So imaging tak perlu bombastic. Only in thyroid swelling. First thing first, after you do thyroid function test, the next step is you need to order ultrasound of the neck. Okay, ultrasound is neck is a gold standard and more superior than CT scan of the neck. It has higher specificity and sensitivity for thyroid nodule only. So in general, kalau ada punya macam colon CA apa benda semua, CT scan is more superior than ultrasound. In case of thyroid punya nodule, ultrasound of the neck is has more superior than CT scan of the neck. So you get ultrasound of the neck, able to distinguish the benign from malignant nodule better than CT scan. So there are lepas ni will show you the malignant features. So the benign and malignant just macam the opposite. Kalau macam malignant solid, in benign there will be cystic. Macam tu, right? Lagi. Alright, so when to do, bukan ada tak boleh nak buat CT scan. You can do CT scan, but depend on the clinical examination tadi. Kalau patient ada compression symptom, patient ada palpable lymph node, you would order CT scan because CT scan is better for a better option for you to visualize the lymph node, particularly the deeper lymph node, and rather than using ultrasound to know the retrosternal extension. So you will also need CT if there is dullness on percussion of the chest. So probably you need a CT scan. Okay. Alright, so kalau PMP korang ada trigger 1, trigger 2, trigger 3. Trigger 1 about your chief complaint, trigger 2 history and physical examination, trigger 3 korang dah dapat dia punya investigation result. So TFT, THS free T4 is normal. So as I told you before, usually in thyroid swelling is patient usually euthyroid. So you would need to expect dia punya TFT is normal. So ultrasound result dia akan bagi summary suggestive of malignancy. So dia akan tanya apa features of malignancy in ultrasound, how to decide for biopsy because next after imaging is your biopsy. So tak semua after your ultrasound, tak semua akan go for biopsy. No, because how to decide for biopsy is okay. Ni the ultrasound features of thyroid malignancy, solid microclassification, and we can do all that. So this is some mnemonic for you to remember what's the malignant features of thyroid swelling. Then body irregular intranodular vascularity taller than wider classification, hyperechoinodule, loss of halo, extraglandular extension, and as well as solid. Korang boleh, kalau tak suka BTS, korang boleh guna creativity masing-masing lah. This is one of the example. So next is when you do ultrasound. So after ultrasound, the report will state the classification. So they will use Thyroid classification. Thyroid macam BRAPS lah. Kalau BRAPS in breast cancer, but BRAPS they use the mammogram or even ultrasound. Kalau patient is younger patient, they will use ultrasound rather than mammogram. Okay, back to thyroid is Thyroid ultrasound classification. They have all these criteria of composition, echogenicity, shape, margin, echogenic foci. Then you so in the description you look for these features, then you add up the points. So this is because the ultrasound will next dia akan macam determine the path of your management lah. So if benign, TR1, TR2, no need FNA. So you don't need to do FNA aspiration. So if TR3 until TR5 is suspicious, either benign or malignant. So all this you need to do FNA aspiration depend on the size. Okay, more than 2.5 cm in TR3, all that. Okay. So for biopsy, the most common use is FNAC, fine needle aspiration cytology. So commonly used either they use fine needle aspiration or fine needle aspiration with ultrasound guided fine needle aspiration. Mainly if you use ultrasound guided fine needle aspiration, it's more has higher specificity and sensitivity. Because kadang-kadang kalau you blindly, probably you are poking into taking the yang safe rather than the more solid. Okay, so for FNAC, we have two classification, Bethesda and Thal classification. In our CPD, they use Bethesda classification. Kalau korang baca Bailey and Love, they use TH1 classification. Both akan determine which one is benign, which one is malignant. What to do, apa dia akan further ni lah. Okay, but if your FNAC, okay, for fine needle aspiration, for Bethesda dia ada 6 kan, 6 punya reporting, punya kategori. If follicular, you cannot determine by FNAC because biochemistry only you look at the structure of the cell rather than for follicular type of tumor, either adenoma, which is benign, and follicular cancer, malignant. You need to see the thyroid as a whole, as a tissue architecture, because only then you're able to find any capsular breach or blood vessel invasion. If this there is presence of capsular breach of capsula, as well as blood vessel invasion, baru it is follicular cancer. Okay, so because the usual practice is usually kalau encounter follicular type of biopsy, kita akan buat hemithyroidectomy. Only then bila ada confirm malignancy, baru kita akan proceed to total thyroidectomy. Maksudnya kalau korang buat hemithyroidectomy dulu, send for biopsy, send for histology, then kalau dia come back as malignancy, and then you need to another surgery. So tak salah kalau macam follicular, kalau korang just cakap buat total thyroidectomy terus pun tak ada masalah. And for medullary carcinoma, you need to do core biopsy. So korang kena tahulah apa beza cytology, histology as well as core biopsy. What's the indication? Okay. Right, so this is Bethesda classification. Bethesda dia ada risk of malignancy for each category kan. Macam tadi AUS or FLUS kan, korang need to repeat FNA. If repeat FNA ni biasanya kalau korang tak buat ultrasound guided in the first final aspiration, so you repeat FNA with ultrasound guided FNA, right? So if benign, you need just clinical follow up. So for clinical follow up, if there is a significant increase, macam korang clinical follow up ni include as your repeat your ultrasound, maybe 3 months, after 3 months or after 6 months. So kalau ada significant increase, korang kena buat FNAC balik. Okay. Alright, so repeat clinical follow up diagnostic. Okay, so this is diagnostic thyroid lobectomy ni yang tadi yang follicular punya ni lah. Kalau follicular, you need this diagnostic thyroid lobectomy. You need the tissue punya biopsy. Then if 5, you straight go to total thyroidectomy, and then malignant confirm is total formal thyroid cancer operation. So far ada question tak? Tadi. Okay, so for thyroid classification, same as Bethesda, just a reporting system. Okay, sama je. Dia akan the same lah. So for thyroid classification, okay, dia ada risk of malignancy juga. Okay. So for staging in general, in kalau staging in thyroid, there is staging macam TNM punya staging, but in general in practice kita tak berapa guna sangat TNM punya staging in thyroid punya cancer. T stage tu important, but N and M jarang lah kita. TNM is they follow the AGCC lah. So usually kalau in local punya, in our lecturer dia akan tanya pasal this staging system, AGs, GAMIS, AMIS, MACHIS. So ni abbreviation to age grade and yeah. Okay. So basically in general for better prognosis is young age group, and also a small size is good prognosis, and no extra thyroid extension, better prognosis. Okay, kalau elderly, large tumor, more than 4 cm, huge tumor, and then extra thyroid extension, for example, retrosternal extension, retrosternal goiter, is worse as worse prognosis. So the reason for using this is for prognosis. We also can help us to plan for REI and TSH suppression, as well as follow-up and surveillance. So next is management. So for management, I said earlier, try to always classify for your management. So you have conservative medical management, surgical management. So for conservative is macam tadi lah, kalau Bethesda 2 which is benign, just follow up surveillance, buat surveillance ultrasound, okay. And then medical management, surgery. Medical management is usually if the patient is as toxic kind, because patient in thyroid, either hyperthyroid or hypothyroid, usually hyperthyroid. So only then they will need medical management. Usually patient is indicated for surgery if patient want to do surgery. Because usually the most common cause of surgery is because of the cosmetic reason, because the patient is woman, female, there's macam low confidence level, having this huge neck mass, ni semua, then they will opt for operation. Okay, so in general, this is some basic principle lah. Know the thyroid status, either you thyroid. If patient not euthyroid, start on anti-thyroid medication. The type of tumor, the papillary, because papillary and follicular size less than 1 cm, you only need to do partial lobectomy. And then if more than 4 cm, you need to do total thyroidectomy. Okay, sorry, less than 1 cm, hemithyroidectomy. So for medical management is really in toxic cases, either toxic adenoma, toxic multinodular goiter, toxic diffuse, which is grave disease. So anti-thyroid medication, you need to know the mechanism of action, side effect profile of each anti-thyroid medication, the carbimazole, the propyl thyroxine, apa benda semua, dan radioactive iodine. Lecturer boleh tanya how is the procedure, what is radioactive iodine, apa benda semua. Okay, and then for this for toxic multinodular goiter, iodide glucose solution, how it the mechanism of action is it interferes with organification and inhibit hormone release. Advantage help to decrease size and vascularity of the gland. Usually we give pre-operatively, reduce the size of the swelling. And then anti-thyroid drugs, carbimazole inhibit the thyroid, thyroperoxidase, thyroid. Okay, dose. Okay, kena dia macam anti-thyroid ni dia macam steroid lah. Korang tak boleh cut abruptly. Korang kena taper down slowly. Depending on the TSA, T4 level. Okay. So only you can stop patient euthyroid at 5 mg. Usually patient kalau 20 mg tu patient kena makan 5 tablet, because satu tablet usually ada 5 mg. Okay. And then side effect of carbimazole, granulocytosis. So this korang kena buat FBC, rash, common lah, cholestatic hepatitis. PTU inhibit peripheral deiodination of T4. Beta blocker mainly it acts not on the thyroid gland itself, but to the target organ of the thyroid. For example, in kalau patient ada tachycardia, so kita bagi beta blocker to act on the heart to reduce the heart rate. Okay, also beta blocker is important to prevent the deionization of T4. So, okay, so we need to stop if patient thyroid. Okay, alright. Okay, ni some notes from ni how we taper down dose. 1 tablet per month, mg. Okay, boleh baca lah nanti. And then surgical management, the indication for surgery, lung suspicious, kalau Bethesda 5, 6, definitely bukan 3 until 6 3 Bethesda 2, 3 3, 4, 5, 6. Okay, there's retrosternal extension, solitary toxic nodule, toxic multinodular goiter, so the cosmetic deformity. Usually we will opt for total thyroidectomy. Korang if answer what surgery is, just answer total thyroidectomy, takkan salah lah, because Okay. Alright, so next pharmacological is post-surgery, post-op punya ni. So you need to post-surgery, immediately day one after surgery, you need to give thyroxine replacement for the patient. Okay, so this is another indication for surgery for C, all the C pneumonic 5C, 6C kan. Cannot be treated medically, cancer, compression symptom, cosmetic, compliance problem. So as well as childbearing, because childbearing there are limited kind of options, such as patient, kalau patient pregnant, you unable to give the RAI because it's teratogenic, and then you for the kalau bagi tu pun korang kena bagi PTU, lower side effect profile in pregnant lady. Okay. And so surgical management, okay, management in papillary CA in general, the general rule of thumbs, if there's less than 1 cm, do hemithyroidectomy, more than 5 cm, total thyroidectomy. Follicular CA, if you do hemithyroidectomy, if the result come back minimally invasive with vascular invasion, they need to need to proceed with total thyroidectomy. First surgery, you remove one lobe, and the next surgery, you need to remove another lobe. Okay. If no vascular invasion, no need to proceed with total thyroidectomy, just move it into hemithyroidectomy, and then you monitor the patient. Unless if widely invasive is total thyroidectomy, like minimal invasive is vascular. Minimally invasive or widely invasive is to the capsular bridge. Okay. Okay, so for lymph node dissections, important in case of papillary CA, where papillary CA usually spread to the lymph node. So if patient have no palpable lymph node, you still also can proceed with prophylactic central, which is you do the total thyroidectomy plus you remove the level 6 lymph node, because people say that because sometimes from your imaging, you can miss from ultrasound, you can miss if there's possible lymph node, or even intraoperatively surgeon pun boleh not sure whether there is lymph node involvement, so they will go for prophylactic central lymph node dissection. Therapeutic if there is a case of lymph node involvement from the first place. So this is type of surgery in thyroid punya surgery, ada lobectomy, subtotal thyroidectomy, hemithyroidectomy, near total thyroidectomy, total thyroidectomy. Completion thyroidectomy is in case of follicular cancer. Okay, very good. Okay, alright. So usually inilah yang mean is usually hemithyroidectomy, total thyroidectomy, completion thyroidectomy. Yang lain semua untuk rarely use. Okay, so kalau orang PNP, dia akan bagi pula tambahan statement one week before elective surgery. Was brought by her parents to ED suspect with lethargy, also had nausea and vomiting, unexamination, a bit confused and oriented to time, person, and place. Temperature 38, which is feverish, tachycardia 20 beats per minute. The result show elevated before. What is likely her current condition, how to diagnose and management? So most probably this patient had thyroid storm. So thyroid storm is rare, but you need to be able to detect and diagnose this, because it is a medical emergency, it has high mortality. So usually in thyroid storm, it is following a triggering event in conjunction with underlying hyperthyroid condition. So in case of macam patient toxic or toxic adenoma, solitary nodules or multinodular goiter, jarang lah yang akan kena thyroid storm. So ni I just want to kalau just in case kalau nak masukkan, nak selit jugalah pasal thyroid storm, because menurut one of my friend yang pernah exam bersama Dr. Aida, if you're a houseman, you're unable to diagnose this thyroid storm, so you are memang fail lah. Memang you cannot become a houseman kalau you can you don't know about thyroid storm. Okay, so mainly triggering event banyak. Macam patient tadi, probably patient ada infection such as UTI then cause the thyroid storm, or even patient probably had been on apa anti-thyroid medication but patient not compliant to the medication. So probably one of the precipitating factor. Other than that is even thyroid surgery. So post-operative patients still can develop thyroid storm or even a non-thyroid surgery because of the non-thyroid surgery lah. Ada surgery lah, contohnya breast surgery ke abdomen surgery ke apa ke semua. It can cause stress to body and can trigger thyroid storm. So korang kena cari, or even patient ada DM and then develop TKA also can precipitate this thyroid storm. Alright, so mainly is clinical diagnosis. So there are two scoring you use to diagnose in thyroid storm. To both this, kalau BWPS and the Japan Thyroid Association is help you to certify the patient which need treatment, which need aggressive multimodal treatment, which may need treatment, which need close monitoring apa benda semua. Okay, patient in with thyroid storm you need to kena manage in HDU lah, high dependency unit or ICU. Jadi ke ICU ke. Okay, so Bershowitowski scale ada few aspect, few features. Thermoregulatory central nervous system effect, gastrointestinal. So you total up the point. For example, this patient 38 kan, 10. Lepas tu dia macam lethargy 30. Lepas tu dia ada nausea, vomiting 10, 40. Then tachycardia 120, 15, 45. So yang ni tak ada tadi. Precipitation history, probably patient ada infection UTI 10, 40, 55. So BWFTS more than at least 45, you need to start the aggressive treatment in the patient multimodal. So what you mean by multimodal therapy is after this. So okay, ni kalau ni pula kalau JTA lah, Japan Thyroid Association. Prerequisite apa benda semua. Symptoms okay, macam patient tadi ada lethargy, fever, tachycardia 120 yang macam patient tadi tak ada. So then you need to grade the TS. If TS1 and TS2 all lah. TS1, TS2 you need to treat the patient. So this is the algorithm for the multimodal therapy for thyroid storm management. Put the patient on high dose propionuracil. Okay. Beta adrenergic receptor agonist, beta blockers such as propranolol. Okay, high dose of glucocorticoid. Okay. Then lubosidine apa benda semua. Okay, korang boleh baca ni. Okay, so next, okay, patient, okay, dalam tier 3 dia akan bagi investigation, dia akan bagi complication, lepas tu patient post-surgery kan. Post-surgery, she underwent total thyroidectomy, discharged after 3 days post-op. During post-op follow-up, she complained of lethargy, intolerance and constipation. So clinically macam patient ada hypothyroid symptoms, then we can during follow-up, kita akan turun juga patient before follow-up, ambil darah, tengok showing low FT, if patient ada hypothyroid. So you need also to know the complication of surgery, because complication of surgery korang akan masa ambil consent patient, korang akan explain each detail of the complication of surgery. So complication juga korang kena classify immediate, early as well late complication. Okay, alright, so this is the complication of thyroidectomy in general. Early, immediate, early, immediate or early, intermediate. So early is hematoma. So how we want to monitor is to prevent is people as currently using apa bipolar diatomy apa benda semua. So this also help to reduce hematoma bleeding set surgery kan. So monitoring post op, usually patient kita akan put the drain. So bila pasal drain, surgery memang suka pasal drain. Korang kena tahu close system, open system apa benda semua, vacuum, all that. So monitoring post op, kita kena tahu ada berapa banyak drain, berapa drain. Usually at least for 24 hours kita akan maintain the drain. Lepas tu kita akan check the wound, tengok ada infection ke, ada breakdown ke apa benda semua. Okay, so also for early is injury intraoperatively can also cause injury to the adjacent. For example, before operation, patient tak ada hoarseness of voice. Post-op, patient develop hoarseness of voice. Probably intraoperatively ada iatrogen injury to the recurrent laryngeal nerve. So it's also important to note before surgery. In the note, korang kena tulis dalam BHT ke apa kalau korang semua ni, kalau korang apa benda semua. Nanti kalau ada pseudo HO ke, kalau korang dah boleh masuk susmed, they can assess the vocal cord via the indirect laryngoscope. Dia tengok the vocal cord status. Dia kena tengok kalau before surgery okay, post surgery lepas tu okay. Kalau okay tak ada masalah. Kalau okay, post surgery tak okay is bigger problem, because recurrent laryngeal nerve palsy can be unilateral and bilateral, can be permanent, just neuropraxia, or permanent, temporary and permanent. So how to reduce this incidence of injury to recurrent laryngeal nerve? Macam kalau korang ENT ke apa ke, they love to use the monitoring intraoperatively. How is you do the nerve monitoring specifically for the recurrent laryngeal nerve? How? Because kalau nak tengok nerve monitoring dalam recurrent laryngeal nerve ada two types, intermittent as well as continuous. Usually in current practice, kalau yang continuous tu just theoretical punya ni. In intermittent korang usually use whereby korang akan introduce electrode inside the endotracheal tube and then put the electrode in between the vocal cord, and then if there is stimulation of recurrent laryngeal nerve, the vocal cord will contract and then it will stimulate the electrode. So akan ada reading. So maknanya we can reduce the risk of injuring the recurrent laryngeal nerve via intraoperative nerve monitoring. Okay. Hari tu I pernah ask one of the ENT, I ask apa beza thyroid ENT as well as surgery, general surgery punya thyroid. They say that ENT will commonly use the nerve monitoring, the need of record Lepas tu macam general surgery memang macam they don't use that much. Macam tu lah. Okay, alright. So next is intermediate is hypothyroidism. So for hypothyroidism, macam tadi lah, patient develop 1 month post-op develop hypothyroidism. Despite on hypothyroidism, probably you need to adjust the dose. Then patient also can have hypoparathyroidism leading to hypocalcemia. So hypocalcemia also is a medical agency. Okay. Yeah, it is due to injury or insult to the parathyroid gland. Usually in total thyroidectomy, they will preserve the vascularity, the vessel supplies, blood supply to the parathyroid gland, the superior and inferior parathyroid gland. Okay, kalau katakanlah ada injury to the blood supply to the total to the parathyroid gland, they will macam tanam parathyroid gland tu inside the nearby structure, for example ACM, sternocleidomastoid muscle. So kalau there's injury inside, because usually in total thyroidectomy they will not remove the parathyroid gland, they will try to preserve this. But if there is injury or insult to the parathyroid gland, can cause hypoparathyroidism leading to hypocalcemia. So this is the mnemonic cats go numb, the symptoms, the clinical manifestation of hypocalcemia patient can have convulsion, arrhythmia, tetany, spasm, numbness. How clinically for physical examination, how you check for hypocalcemia is by this Chuvostek and Trojer sign. So in severe hypocalcemia lead to hungry bone syndrome. So that's why within 1 hour post op monitoring, you also need to send for serum calcium level. You need to calculate for the corrected calcium. Okay. Right. Another is infection. Common is infection. Late is permanent hypothyroidism, which is thyroid failure. So this is post-operative management. For surgery to thyroidectomy post, kita akan go for thyroid stimulating hormone suppression therapy by giving thyroxine. Aim for TSH less than 0.01. Suppress growth of any residual thyroid. You can start as early as day 1 post-op. This is during monitoring whole body scan to detect for any recurrence. If there is a positive whole body scan, we will proceed with radioactive iodine to keep the remnant, then follow up 3 to 6 monthly clinically, as well as serum thyroglobulin and thyroid function test. Take home message. Does the end, take thyroid history. Neck problem is not only about thyroid. So today we only discovered thyroid, but actually the neck problem is more than about thyroid. There are many vital structure inside thyroid. And then physical examination about showmanship, macam cakap tadi, kalau during your short case, your man-oski, it's about showmanship. As the patient, kalau patient duduk atas katil, minta duduk patient atas kerusi. Lepas tu try to ask examiner if there is glass and bottle of water. Okay, patient minum. Okay, alright. And then bila nak inspect tu, korang dekatkan sikit korang punya, janganlah sampai terlanggar patient. Dekatkan sikit korang dengan patient, tengok betul-betul showmanship from the front, from the side, from the back. Okay. So first thing first is no common presentation of common disease. Then uncommon presentation of common disease, barulah korang tahu common presentation of uncommon disease. So prioritize yang common. If kalau korang tahu uncommon, but then korang tak tahu uncommon, yang tahu yang common is tak berguna juga. Okay, so don't dig your own grave. Kalau just answer what you know. Kalau you don't know, just cakap je tak tahu. It will save time rather than lecturer tunggu untuk korang answer benda tu walaupun korang tak tahu. So just kalau tak tahu, lecturer akan move to another question. Okay, try to guide your lecturer things you know. For example, investigation, janganlah aim yang rare apa benda semua yang korang terus cakap biopsy. So probably dia akan cakap so how do you do the biopsy apa benda semua. Rather than that, buat step by step. First send for thyroid function test, then go for ultrasound, cerita pasal Bethesda apa benda semua. So what's the plan? Kalau Bethesda 0, repeat final aspiration with so korang nampak lagi yakin lah rather than korang pergi yang rare, cakap management, buat RAI, all that kind of thing, yang rare apa benda semua, then it check. So in general, try to answer, try to classify and classify. Always classify and classify, baru korang nampak systematic, baru korang tak. Okay, so I think that's all from me. Reference from Swedish Thyroid 2090. This is the list of books you can use.